Good afternoon. I'm James Kazama from Fukushima Medical University. I'd like to express my gratitude for this opportunity. Today, I present a report on the challenging condition known as dialysis-related amyloidosis, DRA, taking into consideration the extensive clinical experience in Japan. It's been known since the 1970s that systemic amyloidosis, characterized by unique bone and joint symptoms, occurs in long-term dialysis patients. The discovery of the precursor protein for these amyloid fibrils, beta-2-microglobulin, was made by Professor Fumitake Geiju in 1985. However, the deposition of A-beta-2-M amyloid is not synonymous with DRA. In families with variants of beta-2-microglobulin, systemic deposition of A-beta-2-M amyloid occurs even in the absence of renal dysfunction or elevated serum levels of beta-2-microglobulin, while these families do not exhibit the bone and joint symptoms characteristic of DRA. On the other hand, in patients with DRA, the deposition of A-beta-M amyloid is observed not only around joints, but also in organs such as the gastrointestinal tract, heart, and tongue, which seen in families with beta-2-microglobulin variants. Even so, bone and joint symptoms are overwhelmingly predominant in patients with DRA. The deposition pattern of A-beta-2-M amyloid fibrils alone cannot explain this discrepancy. Let's focus on the bone cyst. At the periphery of this bone cyst, synovial tissue infiltrates towards the bone. Within this synovial tissue, a robust inflammatory response is occurring, characterized by an influx of lymphocytes and macrophages. Furthermore, along the boundary between the synovium and bone tissues, osteoclasts are lined up. In contrast, the reactive bone formation typically observed in hyperparathyroid bone is entirely absent. In result, bone resorption proceeds unilaterally, leading to the formation of cavities, that is, the development of bone cysts. In usual bone remodeling, CD68 positive cells presenting lung differentiate into mature osteoclasts with the help of supporting cells such as osteoblasts that present lung ligand. However, in the synovial tissue of DRA, infiltrating macrophages and Th17 lymphocytes secrete cytokines such as interleukin 6, interleukin 17, TNF alpha, MCSF, and even soluble lung ligand that induce direct osteoclast formation. This osteoclast formation pathway lacks communication with osteoblasts, thereby leading to a unilateral bone resorption without the reactive bone formation. As evident from this pattern of bone resorption, the symptoms of DRA are not solely a result of A-beta-2-M amyloid deposition, but also the result of non-infectious inflammation. This propensity for inflammation may be an essential distinction, or perhaps the fundamental difference between A-beta-2-M amyloidosis due to beta-2 microglobulin variants and DRA. In the 1990s, the role of advanced glycation end products, AGEs, on DRA was actively studied. Today, the association between AGEs and amyloid formation is largely considered negative. However, I still regard that AGE modification of amyloid fibrils cannot be ruled out as one of the possible triggers for the non-infectious inflammation. Regarding carpal tunnel syndrome, the risk of its occurrence has been decreasing year by year. For instance, in the 1980s, dialysis patients with a history of 15 years or more had an incidence rate of carpal tunnel syndrome exceeding 80%, whereas in the 21st century, this incidence had significantly reduced to around 10%. The risk of carpal tunnel syndrome varies depending on the type of blood purification. Compared to dialysis therapy using the Kupffer membrane, the risk with non-Kupffer membrane dialysis is less than a half. By the early 21st century, Kupffer membrane became quite rarely used for dialysis treatment in Japan, and there is no doubt that this significantly contributed to the decrease of the cases with carpal tunnel syndrome and probably with DRA itself. Furthermore, hemodiafiltrations and the beta-microglobulin adsorption column reduce the risk to less than 1/10. Among these methods, the beta-microglobulin adsorption column is used in line with the circuit during dialysis session and has been in use in Japan since the 1990s. 3 decades have passed, and while the number of patients with DRA has decreased, the beta-microglobulin adsorption column is still being used in some patients. The rationale for this is clearly illustrated by this graph. In the placebo column group, joint pain persisted, and over time, joint stiffness developed along with limitation in activities of daily living. Conversely, in the beta-microglobulin adsorption column group, pain was diminished, resulting in a reduction of joint stiffness and ADL restriction. The pain-relieving effect becomes apparent shortly after the initiation of the column use. Unfortunately, the effect of this treatment rapidly diminishes upon discontinuation. While the reason remains unknown, many clinicians regard that removing beta-microglobulin merely through hemodiafiltration does not improve these symptoms. Therefore, this treatment continues to be adapted for DRA cases with severe symptoms. Is this truly not a placebo effect? We are not sure. Currently, we are conducting a survey involving long-term hemodialysis patients residing in Japan who have undergone this treatment for more than a decade. We hope we can provide a comprehensive report in near future. Now, I'd like to discuss why the treatment with beta-microglobulin adsorption column improves joint pain, drawing from research conducted over 20 years ago by ourselves. Long-term dialysis patients were intravenously injected with iodine-131 labeled beta-microglobulin monomers, resulting in the accumulation of tracer around major joints. Of note is the fact that while the tracer accumulates around the joints, there is no accumulation in the liver. Immediately after capturing this scintigraphy, the patient underwent surgery for carpal tunnel syndrome. The tissue obtained during the surgery is shown here. The tracer was not incorporated into the amyloid tissue above. Instead, it was found that macrophages, which were roaming around the amyloid tissue, had taken up the tracer intracellularly. For over 20 years, I couldn't find the appropriate interpretation for these findings. The tracer introduced is a free beta-microglobulin monomer, which precisely corresponds to the substance absorbed by the beta-microglobulin adsorption column. Of course, these fresh beta-microglobulin monomers are unlikely to be modified with AGEs. Instead of being taken up by amyloid, it is assimilated by macrophages surrounding joints. However, this uptake does not occur in all macrophages, because approximately 80% of the body's macrophages reside in the liver. Why does this happen? What's the significance? I had no idea at all. In recent years, a study has been reported that might provide a hint towards understanding our findings. When beta-microglobulin monomers were added to cells transfected with inflammasome components, along with adapter proteins and pro-inflammatory cytokines, the thioflavin T fluorescence response was enhanced. Furthermore, A-beta-2-M amyloid fibrils directly interacted with the inflammasome, leading to the increased production of IL-1 beta. Namely, macrophages take up beta-microglobulin monomers, initiate intracellular amyloid formation in an inflammasome-dependent manner. The formed amyloid fibrils remain resistant to cellular degradation process, and they directly interact with the inflammasome, triggering the release of inflammatory cytokines. If this in vitro finding is reproducible in vivo, circulating beta-microglobulin is initially taken up by macrophages surrounding A-beta-2-M amyloid depositions, and A-beta-2-M amyloid fibrils are generated intracellularly concomitant with the induction of inflammation. And if the beta-microglobulin adsorption column is indeed interrupting this reaction cascade, it could explain the clinical course where pain disappears promptly after the use, but symptoms recur immediately upon discontinuation. It is still uncertain whether this hypothesis is correct, whereas it is certain that the beta-microglobulin adsorption column does not demonstrate its effects through a straightforward mechanism such as depleting A-beta amyloid fibrils by withholding the precursor protein beta-microglobulin as we had envisioned during its development in 1990s. The pathogenesis of DRA is not so simple, and we still do not fully understand it. We have not yet succeeded in eradicating the condition either. There are still many patients with DRA in Japan. We have yet to overcome this challenge, and indeed, we still have a long way to go. Thank you for your attention.